Well, let's think about that. I mean, we want to treat relapses. What are our goals when
Mhm,
we are doing that? A patient comes to us, we assess
mhm.
that they're having a relapse. What's the treatment goal with that initial response to an MS
Well,
relapse?
we see the patient at the time of symptoms that they notice, or much less commonly, we see them incidentally because they were scheduled to, and it's like, what's going on here? So we have what is obviously some kind of objective change, whether it's a sensory event that's more subjective for the patient. It's clear that something's changed, and our goal is to assess when did this start. Is it getting worse still? How bad is it gonna get? What's the prior history? And, how can we appropriately treat it? What have we done before? How have we managed this person's relapses? Were we successful? Younger people, they tend to come on faster and resolve faster when we treat them, presumably because of the nature of the inflammation. Older people, it can be much more gradual. It can be very gradual in onset in people who are on therapy as well. So what I have to ask myself is, how bad is this going to get? Is this something that I have a very great deal of comfort because of the nature of the event? It's really not a disabling sensory event. It might be painful. It might require symptomatic treatment, but to resolve the event, unless it's really quite exquisitely painful, you may need to do nothing except treat it symptomatically. And similarly, some very unpleasant symptoms can be very benign relapses with vision or vertigo. But you also have relapses that mean a lot, like the legs and the bladder aren't working, where there's a really big liability here for other things happening, for injury, for occupational disability, that you want to not only treat, but you want to make sure you're assessing that person, that the treatment was enough and it's effective.
So I'd like to pick up on what Sam said. When you walk down the center of the campus at the University of Pennsylvania, you find the aphorisms of Benjamin Franklin. Why? Because Franklin started the University of Pennsylvania, among which is an ounce of prevention is worth a pound of cure. What is a relapse telling us? A relapse is telling us that this disease is still active. And that's why it's critically important, I think, for us to identify the relapses, because that disease is still active. Whether you treat the relapse or not, you know that disease is active, and you know whatever you're doing for the patient at that point in time is simply not working. And it may lead to a change in the disease-modifying therapy that you're using. And I'd also like to add that we think that individuals, just because they seem to improve very often following a relapse, have gone back to their baseline, but generally they don't. It's probably 50% that may. If you look at the optic neuritis treatment trial, which I think is quite informative in this regard, they found that at 6 months, everybody who had optic neuritis still had impaired visual acuity in some way, shape, or form. And when they looked at them 15 years later, a quarter of them still had significant visual acuity. The patient may not recognize it. How often do we see patients who have had optic neuritis and you say, well, which eye did you have the optic neuritis in? And they go, I don't know, doc, it was 5 years ago. I can't tell you. But if you look hard enough, you find that there's an abnormality. So if the treatments that we have for relapses are effective in delimiting that inflammation, it likely has a role in decreasing whatever permanent damage is left.
I think that's a great point. And the idea about being even more sensitive to subtle findings, either of a relapse or from a relapse, I think is a direction our field is moving, to try to develop more sensitive ways of measuring some of these things. Rob, maybe you can speak a little bit to how the Cleveland Clinic uses its infrastructure for early identification of relapse, or looking for subtle consequences and prognostic implications of a relapse.
Sure. So, I think if we're talking about identifying relapses, one of the most important points is providing something that pediatricians are always really good at, and that's anticipatory guidance to our patients. So, one of the questions that many patients have, and only a few of them ask, is what should I call the doctor for? What sorts of symptoms should worry me? And so I think even just a minute or so of conversation with a patient who's newly diagnosed in an exam room to reassure them and tell them that most patients' relapses do not occur 3 times a week, do not occur once a month. They're an infrequent event. And they're things that last, they're neurological symptoms that last longer than 24 hours, and that we're available. And if they're having a new symptom that lasts longer than 24 hours, they should call us about it. And so, the first thing we do is instruct the patients about what to call about, basically. And we actually, at Cleveland Clinic, we monitor patients' neuroperformance. And so that means checking different domains of neurological function quantitatively over time. So that includes cognition, it includes low contrast letter acuity vision, it includes manual dexterity and walking speed. And we also have patient-reported outcomes that we collect at each office visit. And so we can literally plot those out over time. And if we've had a history on a patient for a while, you can see whether those numbers are stable or changed. And if there's been a deviation from things, if all of the numbers are off, you're suspicious that maybe there's something else going on. If especially the depression measure potentially, or anxiety measure that we collect on patients at every visit. And if you see that, oh yeah, the walking speed is off and they're having these lower extremity symptoms, it helps to have the neuroperformance and the patient-reported outcomes monitored. And so instruct the patient to call when they have symptoms that we would worry about. Have these numbers on file for the patients and the ability to plot them over time, and then get them checked out. Like Amy said, our options have really expanded a little bit, and whereas the options used to be just talk to them by phone and figure something out, or bring them in for a visit, there's an in-between option now at a lot of places called virtual visits, where you could see a person via a video link from their smartphone, and you can actually kind of talk to them face to face with a provider and assess them. And that's become an increasingly common way for us to assess patients with new symptoms at our center.
It's a good middle ground between the phone call, where you can't always get a full sense, and having the person come in geographically might be difficult for them.